Hello, welcome. Dr. Holly Thacker here. I am a site director at the Cleveland Clinic, and I'm a professor in medicine and OBGYN and reproductive biology. And I'm going to spend the next 7 to 10 minutes talking to you about some important points as part of this program. I really want every physician and APP and healthcare clinician to understand that there are very few absolute contraindications to menopause hormone therapy. Most women within 10 years of menopause should, in fact, be offered menopausal hormone therapy for symptom control, reducing disease burden of several chronic conditions, as well as anti-aging purposes. And women under 50, particularly those women under 40, which is 1% of women have premature menopause, they are very special and they need hormone replacement therapy, which is generally higher dose than just regular hormone therapy for the naturally menopausal woman. And it's important for you and your staff to engage menopausal women in shared decision making regarding hormonal as well as non-hormonal treatment options. For vasomotor symptoms, classically hot flashes and night sweats, but there's a whole panoply of other symptoms that are part of that symptom complex. Bone health, since half of all women by age 55 have osteoporosis, as well as genitourinary syndrome, which affects most women post-menopause. Now, as I mentioned, younger women deserve hormone therapy, and older women who just simply have continuing birthdays and have a birthday past age 65 should not be discriminated against solely based on age, even though dosage adjustments, reevaluation may be needed. It's very important, and this is something I've emphasized with my trainees in the Fellowship for Specialized Women's Health, to understand the difference between chronologic age, which you can just look on your birth certificate and figure out how old you are, as well as your age of menopause and hormone deficiency, and how long you've truly been estrogen deficient. Now, women that have premature ovarian insufficiency, sometimes their ovaries may work a little, a lot of times they don't, as well as women with surgical menopause or premature menopause, or menopause induced early because of chemotherapy or radiation. That whole group of women who don't have the usual reproductive time frame of hormone exposure are at increased risk for cardiovascular disease, osteoporosis with subsequent fractures, sexual dysfunction, genitourinary syndrome, as well as a host of neuropsychiatric problems. So this is a medical condition really deserving of evaluation and treatment. Now, the list of so-called contraindications to hormone therapy is dwindling. On the left part of your screen was the old 2017 Menopause Society, which was renamed from NAM's position statement, that had a lot of list of things. And really, the most updated position statement from 2022, really the main contraindication is unexplained vaginal bleeding, because 1% of the time it can be uterine cancer. So in someone who has unexplained vaginal bleeding that's not induced or cyclical, it does need to be evaluated. And really the only other absolute contraindication to estrogen therapy would be LAM, lymphangioliomyomatosis. Now, the Menopause Society lists liver disease, and I qualify that by you would just use transdermal, not oral. They also list prior estrogen-sensitive cancer, and I think routine practitioners may not want to prescribe, but certainly specialists with informed consent and shared decision-making with women can certainly evaluate this after the woman has completed her cancer treatments. Prior heart disease is listed, and I disagree with this in that once someone is stabilized, just because they have the burden of heart disease doesn't mean they should have to also suffer the burden of menopausal symptoms. Now, there are great non-hormonal alternatives. We have some new ones that you'll hear about, but some women still will choose to use hormone therapy. And in cases of heart disease, hypertension, prior stroke, prior MI, all of those conditions should be stabilized, but then usually transdermal hormone therapy can be used. Now, prior blood clotting, venous thromboembolism, pulmonary embolism, which are life-threatening, we would never use oral estrogen. But again, there is a role for transdermal therapy. And just because a woman might have a genetic predisposition and might have suffered from clots and might have to be on lifelong anticoagulation, doesn't mean that her menopause doesn't deserve to be evaluated and treated. Now, the risks that were removed from prior recommendations were common conditions: endometriosis, migraine headaches, fibroids. All of these are very common conditions in women, and they are not, repeat, not contraindications to prescribing hormone therapy. Just think about, is there any contraindication to prescribing insulin in someone with type 1 diabetes? No. Is there any contraindication in giving thyroid hormone to a woman who's had her thyroid ablated for cancer? No. Now, do you have to know about the dose? Do you have to monitor them? Does that maybe change with age and other medical conditions? Absolutely. However, to just absolutely say, oh, no, you can't have hormone therapy because your ovaries have stopped making estrogen, and oh, too bad for you, has really been too much of the attitude of the healthcare profession in the last, 22 years since the Women's Health Initiative. And so thankfully that's changing. And obviously you've made a commitment to being part of that positive change by being part of this program. So good for you and good for your team. So, common issues, as well as rare and more serious issues, are generally not reasons to withhold hormone therapy. And also, neither is a clinician's fear or lack of knowledge. And so, you obviously are getting educated right now, which is wonderful. And a lot of your patients are very fearful as well. And that does tend to be one of the barriers. But we have lots of great resources for our patients. And as I mentioned, just because you have a few more candles on your birthday cake doesn't mean you have to be abruptly taken off hormones. You need to be reevaluated. You might need a lower dose to reduce the risk of stroke, might want to transition to transdermal, but there's never an absolute age that someone cannot be on hormone therapy. Now, women that are very high risk, you may feel more comfortable recommending consultation with a menopause expert. There's only, a little more than 1,000 certified menopause practitioners in the United States. So clearly, that's not enough people to see the rank and file routine midlife women. But in women that do have cardiovascular disease, we obviously stabilize that. Um, and in general, if a woman has known atherosclerosis and is over 60, then the combination of hormone therapy and statins is actually better than just statins or just hormones alone. Um, Generally speaking, when you're giving something purely strictly for prevention, primary prevention, there really cannot be any risk. And there are risks with hormone therapy, but most of the women interested in hormone therapy also have some symptoms and or are willing to accept some risk in order to reduce common disease burdens. And the major risk with hormone therapy, especially oral estrogen, is the risk of venous thromboembolism. And using estrogen plus progestin is actually a greater risk than estrogen. If you have a woman with a hysterectomy who doesn't need progesterone, transdermal estrogen patch is really a no-brainer. And I get so many consults, women who have had hysterectomies, they're on the patch, and then nobody will give them refills. And that's really a waste of resources. It's not fair to the woman. If there's no bleeding and it's transdermal, generally speaking, there's really no reason why that woman cannot continue. Now, you might want to measure an estrogen level. Maybe you might want to alter the dose, give more, give less, maybe change from a weekly patch to a twice weekly patch if the patch isn't staying on the whole week. But that's really very simple for hysterectomized women. Now, the issue, of course, in most women's minds is breast cancer. And over 5 years of estrogen plus progestin in the Women's Health Initiative showed reductions in overall mortality. And in women with estrogen alone with hysterectomy actually showed reductions in breast cancer. So most experts in the field do not believe that increased risk of breast cancer is a risk, even though that's what most clinicians and women think. Now, oral estrogen does increase gallstones and may increase triglycerides. If you just use estrogen and there's an endometrium, i.e. uterus, there is an increased risk of uterine hyperplasia and cancer. And if you take a woman off hormones, just arbitrarily because you think, oh, they've been on it too long, again, think insulin, think thyroid, you don't do that in those conditions, then there's actually a higher risk of heart attack and stroke, especially in women under age 60. So there's a risk in taking women off of therapy. And importantly, we should pay attention to that midlife group of women 40 to 60, because there are alternatives to treat the bone if they don't have hot flashes and or they don't want hormones. There are great bone options. We have local options, hormonal and non-hormonal, for genitourinary syndrome of menopause. But it's important to engage women and let them know that the benefits outweigh the risk for most women, and to incorporate questions about hot flashes and hot flash equivalents, and ask about sleep and mood and sense of well-being and sexual health concerns and sleep, and engage the patient in shared decision making. Now, the special populations like early menopause, premature menopause, premature ovarian insufficiency, are patients that have gene mutations that many times lead to an earlier surgical menopause. Those are special women that usually need higher doses of treatment, but are still certainly eligible for therapy, including women who've been on hormones all along and just happen to have a 65th birthday. And some of the resources that we have available are, of course, on menopauselearning.com, our Advancing Health After Hysterectomy. The nonprofit that I run, speakingofwomenshealth.com, has free treatment guidebooks, patient engaging information on social media, non-branded information. And we have a podcast on all the podcast channels, Speaking of Women's Health, some of which has included free CME for healthcare clinicians. And a lot of our patients, it's mainly geared, most of the podcast, to lay women, helping them understand this whole process and be good partners with you in your practice. Thank you so much.